Hello. Now we get to move on to chapter 20. And this is where we get to start talking about cancers and how they happen, how to treat them, etc. So, cancer terrifies me because it's basically uncontrolled cell growth that we can't reel in, and so it can go all crazy, and that's not fun. All right, so some terminology that we need to know are that each cell differentiates or divides, grows into its own little thing, and it carries out particular functions. And those functions are predetermined, like by genetics, right? So this cell knows it's going to be a skin cell. This cell knows it's going to be an eye cell, etc. The only difference is like stem cells are not differentiated yet. So that's how we can kind of train them to become what we want to in, for instance, cancer therapies. And each structure is going to reflect the function of the tissue. What this means is, like, striated muscle is going to be in the heart, right? Cardiac muscle, or, different types of muscles are going to be different places in the body. And so the structure is going to be relative to function. Mitosis, this is the cell division of your body cells. So there's meiosis, which is your gametes, which would be your eggs and your sperm. And then there's your mitosis, and that would be the cellular division of your actual body cells. And so I always think of my toes. So toes are body cells. So mitosis would be part of that cell cycle. And this requires genetic control of both DNA and RNA. We also have mutations, and these mutations can be bad or they can be benign. And so if a DNA in the parent cell is altered and passed on, then the offspring cells will carry on that mutation. And so that's why, like, genetics inherited, I inherited some things from my dad right there, and they are passed on to me. And if I would have had children, I would have had a 50-50 chance of passing them on to them, right? And so these genetic mutations can be passed on throughout the generations. Apoptosis, this is what we talked about before in this last week's lecture. It's programmed cell death, and this is not necessarily a bad thing. Like I said, we all have like webbed fingers and toes, and then through apoptosis, they split apart and we actually get our individual fingers. And so this is going to be controlled by those genetic elements. Like I said, it's not a bad thing. So neoplasms. Well, neoplasm or tumor, let's distinguish between the two. And so, this is going to be on the first part. This is actually the whole title of your entire chapter. Chapter 20 is Neoplasms and Cancer. So, what is neoplasm? Well, a cellular growth that no longer responds to cellular genetic controls. The cell continues to reproduce without a need for them to reproduce. And so it just is like, well, you don't need to, but I'm still going to take over and keep reproducing. So it's like that cell growth, even though we're not asking it to grow. This will deprive other cells of the nutrition because they're always competing for different nutrient availability, right? We only have so many nutrients in our body, so many nutrients circulating in our blood cells, etc. And so they can outcompete the healthy cells that we want to keep by overpopulating. Neoplasms may consist of atypical or immature cells, and there are characteristics of each tumor, and these depend on the type of cell from which the tumor arises, as well as the unique structure and growth pattern of that specific tumor. So when we're talking specifically about nomenclature, or the fancy scientific names, benign tumors have tissue plus the tissue name plus the suffix oma. For example, adenomas, where malignant tumors that are cancerous have the name of the tissue plus the suffix carcinoma. For instance, adenocarcinoma. So if it's just an oma, then that would be benign tumor adenoma. If it's cancerous, cancer causing, right, then that would be the adenocarcinoma. So they throw that carsa in there, okay? And the tumors of connective tissue are usually termed sarcomas, and they're more often than not malignant. Several different malignant tumors have unique names as well, and these are ones that we are going to talk about in class, and that they're more, not popular, but they're more known in the mainstream. And so this would be Hodgkin's disease, Williams tumor, and leukemia. So looking at your tumor nomenclature, this is on table 20.1 on page 547 in your book. And so if your root word, because I'm huge about root words, is lipe, so that would be your fatty tissue, because Lipolysis would be like the breakdown of lipids. Lipids are fats, right? So lip would be your fatty tissue. And then if it's benign, it would be an oma. So lipoma would be a benign tumor of that fatty tissue. Where if it was the gland tissue, it's going to be in your adenoids, right? And so that would be the adeno. And then it would be cancerous, so it would be carcinoma. So then link those two together, and it would be adenocarcinoma. And this, for instance, would be a malignant tumor of epithelial lining of a gland. Or we have the fibrous tissue, and this would be the prefix or the root word of fibro, and then the end suffix would be malignant or sarcoma, right? So the fibrosarcoma would be a malignant tumor of the fibrous tissue. So if you really work on paring down those keywords into the roots, like the prefix and the suffix and any of the other words that would be in the middle, then it can really help you steer into what the tumor is actually trying to tell you. What about benign and malignant tumors? And so this is started on page 547. Well, benign tumors usually are differentiated cells that reproduce at a higher rate than normal. They're encapsulated so they don't spread, and they do cause tissue damage. And this can be a result of a compression of adjacent structures. And these can be life-threatening. So even if I have a non-cancerous or a benign tumor in my brain and it starts pushing up against my respiratory center and like the brainstem area, then that's going to compress those areas that I need to have my vital signs and my respiratory rate, heart rate, all that stuff controlled. And so that can be life-threatening even though it's non-cancerous. Then you have those malignant tumors, and these are undifferentiated, non-functioning cells. And so with them, they kind of take off like wildfire. They have rapid reproduction, and they have abnormal mitotic figures. And these can infiltrate and spread into the surrounding tissue, and that's why they're benign or malignant, because they're spreading, right? And they're just kind of like dragon claws, and they like grab onto things. And these can also spread to distant sites, right? So the malignant tumors are, the bad guys, right? So with this, we have a fun little summary table, and this is table 20.2, and this again is going to be on page 547. And these are going to be those characteristics of the benign tumors and the malignant tumors. So the cell, the differentiation of growth, the spread of them, and then also systemic effects and whether or not they're life-threatening. And again, with the benign tumors, it really depends on location. And so this is a really good summary table. So this is going to be a fun little picture. Well, they're never fun when we're talking about cancer, right? But a picture of characteristics of benign and malignant tumors. And so this is on figure 20.2 on page 548 of your book. And over here, you can see that it's that encapsulated guy, right? And so this is going to be that benign, slowly expanding mass that is encapsulated. That compared to the malignant tumor is going to be where the malignant one has the irregular shape or surface, that has the abnormal cells with the abnormal irregular size and shapes. And then you also can have necrosis, or the dying tissue that's being starved off because it's being outcompeted for nutrients. We also can have the invasion of the blood vessels, which then gets you on the highway express system of the body, and that's how one of the ways that it can spread so rapidly. So with specifically malignant tumors, let's talk about cancer. Basically, cancer is when there is a lack of control of that mitosis and they do not undergo apoptosis. So we can't control the cell replication, which is the mitosis, and they don't stop growing and we can't tell them to die, right? So apoptosis again is going to be that programmed cellular death. Well, if that's not there, then they don't have any stop signs, right? They can just keep going and replicating and start spreading, right? So the malignant tumors, specifically cancer, are going to be the lack of control of that cellular division, as well as not telling them to die off, okay? Not being able to. There's no normal organization or differentiation of these cells, and there's no contact inhibition. They have abnormal cell membranes, and they also have altered surface antigens. And because of this, they're not going to adhere or stick to each other. And so adhesion is a fancy word for sticking together, right? So adhere is the root of that. So they don't adhere to each other. And so because of this, they're kind of like, gummy worms hanging together, but they're not glued together. Well, one can break off and just go wherever it wants to, and so it can break loose from that mass. And when it does that, it can spread, and it can also therefore invade other tissues, and it may spread to other distant sites as well. The mass can compress blood vessels too, right? So as we're growing and it's like not stopping because it's cancer, right? It just can compress on blood vessels wherever they are. And so then this can lead to the blood supply being cut off of that tissue. Without the blood supply, we're not getting the nutrients that we need, and we're not getting any of the byproducts and the waste removed. And so this can lead to the necrosis, or the death of that tissue, as well as inflammation around that tumor. And the tumor cells may secrete enzymes or hormones as well. And these can be proteolytic, right? And so they can break down proteins and different cells. And when we do this, this can have a variety of different effects. And some of them are systemic, which means they're about the whole body. Okay, it's not just localized to one area. And one example of this could be altered calcium levels. Well, if you remember back to physiology, the sodium, potassium, ATPase pump, the calcium levels, all of those are very important in muscle contractions, right? If you throw off your calcium levels, you can throw off a whole bunch of different procedures that happen in your body, and you can cause a lot of problems. So you can see that by blocking like calcium level, like the production of calcium or the absorption of calcium or distribution of calcium, you can lead to a lot of different systemic effects. We also have inflammation and loss of the normal cells, and this can lead to the progressive reduction in the organ integrity and function. So say that I have this in my liver. Well, if it starts taking over and keeps growing and growing and growing, eventually I'm not going to have normal little liver cells, right? It's going to be taken over by these like little monster cells, right? We can also have angiogenesis, and this is where, angio would be the blood system, genesis means to make. So angiogenesis is basically making new capillaries or a blood supply. And so this happens because some tumor cells secrete growth factors. And because of this, those growth factors can stimulate the development of new capillaries in the tumor, therefore giving it its own little nutrition system and allowing it to grow quicker, faster, and better than the normal non-cancerous tissues. So on page 4, I'm a little dyslexic, sorry, and it's coming out today. So on page 549, here is a nice little summary table of the warning signs of cancers. And so you have to really be your own body advocate, right? And make sure that you're paying attention to these different things. So if we have unusual bleeding or discharge anywhere in the body, that can not be a good thing, right? And that could potentially lead to cancer. You can have a change in your bowel or bladder habits. An example of that would be prolonged diarrhea or discomfort in the bowel bladder area. You can have a change in a wart or a mole. And examples of this would be like the color of the mole, the size, the shape, right? So you have to just, any little freckles and moles that you have to keep an eye on them, right? Also a sore that doesn't heal, and this can be either in the skin or in the mouth, basically anywhere. So if you have a non-healing sore, keep an eye on it. Unexplained weight loss, anemia or low hemoglobin, persistent fatigue, right? Because remember, those cancerous cells are like leaching nutrients from your healthy cells and causing you to have some of these symptoms. A persistent cough or hoarseness without a reason, and also a solid lump. Often it's painless, but the solid lump can be in the breast or the testes or anywhere in the body. So you really have to keep an eye on everything to make sure that we are A-okay. So what are some local effects of tumors? And this is on page 549. Well, you can have pain, and this may be absent until the very late stages of that tumor. And so that's why you have to do regular exams to see if you can, feel any lump or see anything that's different, because the pain might not be there until the later stages. And sometimes those later stages might be a little too late to help. This could also occur when the tumor is well advanced. So that's why we do screenings to try to catch them quickly. And the severity depends on the type of tumor. You can also have obstruction, and this occurs when the tumor compresses a duct or a passageway. A blood supply or lymphatic flow can be restricted depending on where that obstruction is. Like if you have a growing tumor, it can obstruct your digestive tract, and that's no fun, right? You can also have an obstruction in airflow of the bronchioles in your lung, okay, the bronchi. And so you have the two lobes, and then it goes into the bronchi and the bronchioles, and then the alveoli, so all the little guys. So you can have blockage down there, and then the oxygen exchange and the nutrients aren't getting to the tiniest little alveoli. Also tissue necrosis and ulceration. And this may lead to bleeding or infection around the tumor. So always kind of just make sure that you're paying attention to these things. This is an example of obstruction by tumors, and this is on the bottom of page 549. And so you can see here that the little green guy, if it has a tumor blocking the airflow in the bronchioles, or then it's not going to be able to get to those little alveoli and the other different lobes, right? So then if you're not getting oxygen to that part of your lung, that whole part of your lung is going to die off, and that's not going to be very cool. Or you can have, an external mass that can be pressing up against the colon, or, the circumferential tumor, which can again be pressing up on either side. You can have a pyloid tumor or a polypyloid tumor. But regardless, you can see it's kind of like if I put a ball here or I press up against that part of your colon, the flow and the movement through the colon is going to be obstructed. So what about some systemic effects of malignant tumors? Well, you can have weight loss or cachexia. This can cause anorexia, fatigue, pain, stress. This can have increased demands on the body from the tumor cells that are going to cause you to, the anorexia, your body's not getting the nutrients even though you may be eating them. You can be tired because, again, you're not getting the nutrients that you're feeding your body, etc. It can cause anemia, and this would be caused by the blood loss at the tumor site. So remember that tumor site can start making small little blood supplies, right? So then it's redirecting the blood from the vital organs that need it, and it's feeding the tumor. And so these nutritional defects may reduce hemoglobin synthesis. And remember, synthesize means to make. Hemoglobin is what carries the oxygen in our blood. So nutritional defects may reduce the way that our hemoglobin can carry blood, or the amount of hemoglobin we have to carry blood in our body. And all of these together can cause severe fatigue. And so this fatigue can be caused by the inflammatory changes, the cachexia, the anemia, right? And so you have to really stress a treatment schedule to try to get things under control. And I think this one's more meaning like it will stress your body out too to follow the treatment schedule. So you can look at it either way. And there's also psychological factors. I mean, if you're exhausted all the time, do you think that you can study for school and go to work and raise the kids and try to be a good wife or husband? There's just a lot of different downstream effects that can happen. You can also have effusions, and this is inflammation that causes the fluid buildup in body cavities. You can have infections, and these occur frequently as the resistance declines. You can have bleeding, and this is where the tumor cells may erode the blood vessels. And you can have paraneoplastic syndrome. And this is associated with certain types of different tumors. And the tumor cells release substances that are going to affect the neurologic function. And this neurologic function can have hormonal effects because, neurologic brain controls a lot of our hormones, right? And our different signaling molecules or pathways. So how are we going to do diagnostic tests? Well, this is on page 550, and like the biggest one is to have routine screening. And so this is going to be essential for our early detection. And so following the detection, then we would have to follow a treatment plan to detect any further tumors, okay? Also, those self-examinations are going to be very important because we really need to see if we can have an early detection system to, spot any different lump that may be in your breast, in your testicle, on your skin, any shapes changing, colors changing, etc. So that's why they say do self-examinations when you're in the shower. Also, excuse me, we have blood tests, and these we can measure the blood cell levels that happen during the treatment or as they occur during the treatment. And we can use these to detect tumor markers for existence, the PSA test in, I think that's the prostate. We can also have a radiograph, okay, an ultrasound, MRI, CT. These different methods are to visualize changes within the tissues or within the internal organs. Okay, we can't just cut you open and look at it to say, oh yeah, it's still the same. Okay, sew her back up and, stick her out in the road and see her in a year. So we have these other diagnostic tests that we can look internally that are less invasive, right? And then we also have cytological tests that these do require biopsies or cell samples in order to perform them. And so, oh, sorry, I worked out, and so now my body's coming out down. And it's like yawning because it's like, I need oxygen. All right. So the cytological tests are again going to require that biopsy, and then we look at them under the microscope and look at the histology or the cytology to determine the degree and the differentiation of the tumor type. You may be tested for growth promoter sensitivities, for instance, estrogen dependent tumors, etc. And this is the most dependable confirmation of the malignancy is using the cell test, the blood tests, and the biopsy to look at the cell structure. Apparently my brain just decided to take a break on me. We also have genomic tumor assessments, and these identify genetic mutations that are independent of heredity, but they only occur within the disease itself. So how about the spread of malignant tumors? Okay, and this is starting on 550, and it mostly is on page 551. So we have the invasion, and this would be where we have the local spread, and the tumor cells are going to grow into that adjacent tissue. And an example of this would be the uterine carcinoma that can invade the vagina, right? You also have metastasis, and this is where the cells metastasize and they spread to distant sites. And this can happen through the two highways that I talked about. One is the blood lymph system, because blood goes from head to toe, or the lymph system, because again, you have lymph nodes everywhere. And this can also occur through different bodily fluids. An example would be carcinoma of the colon can spread to the liver. So this is on page 551, and this is an invasive carcinoma of the cervix in a woman, okay? So the little orange dot here is the carcinoma in situ, and this is non-invasive. And so this would be what it would look like normally, and so you have your basement membrane, and then you have the tumor cells in situ, okay? And then you have step 2 here, which would be the cervix invasive carcinoma. And you can see it's growing. And when we look at the cellular structure, I'm looking at my book over here. When you look at the cellular structure, you can see that the basement membrane that was kind of keeping it contained is now broken, and those cells are allowed to proliferate. Well, then you can have it spread, and now the vagina is going to be involved. And after it's spread to the vagina, then it continues to spread, and it can have widespread invasion, and it can go from the vagina to the urethra to your urinary bladder to your uterus to the colon to the rectum, right? So you can see how just a little bit can grow into making a rather large carcinoma of the cervix. What about metastatic breast cancer? Well, this is on page 552, okay? And so this is figure 20.5. So up here, you have your primary tumor, and basically it hops on the highway express. Over here in the green is the lymphatic vessels, where in the blue over here is going to be the vein. And then it can get to the lymph node, and they can go together and hop on and kind of coalesce, right? And they combine, and then they hop on the highway express of the vein. And then these tumor cells down here in step 4 can lodge in the hospitable capillary bed. Hospitable means it's very inviting. I mean, there's nutrients there, right? You're getting a ton of oxygen exchange. You're, getting rid of waste, and you're picking up the good nutrients. So it really kind of wants to be there because that's where it's going to get the most bang for the buck, right? And then down here in 5, the secondary tumor grows and spreads. And then down here in 6, you have multiple tumors that can now be established. Over here you have this is breast cancer. So down here in 1, you have the primary breast cancer that can be located, and then oops, no, don't do that. Okay, and then the star is going to move to this little dot, and this is where it's going to be spread to the auxiliary lymph nodes. And then in step 3 here, it's going to follow the lymphatic to the vena cava, which again is like huge blood supply, right? And then the vena cava is going to feed it over here to the fore, which is allowing the lung metastases. And then after that, the aorta is going to carry the tumor cells from the lungs to all organs. So you can see why I call it the Highway Express, right? If you guys have, I love this movie. It's called Osmosis Jones, right? I love Osmosis Jones, but it kind of shows you a cartoon version of all the different things in the body and how they interconnect, and it's really cute. Okay, so I would really suggest watching it. It's fun. It's a kid's movie, but there's a lot of adult good knowledge in there. All right, so anyway, the aorta is going to continue to carry the tumor cells from the lungs to all organs, and then you can down here have ovary metastases, or over here have liver metastases, or up here have brain metastases. So you can see, again, once it hops on the Highway Express, it's just a free-for-all. And so we really want to try to catch things before they can get to that metastatic level. So this here is figure 20.7, and this is showing you the ovarian cancer spread through the pelvic and the peritoneal cavity fluids. And so here, again, you have your primary ovarian tumor, and then you can have continuous peritoneal membrane that's there, and you can see it starts to spread, and then as it continues to spread and grow, it goes up to the secondary level liver tumor. So the primary tumor started down here in the ovaries, and then since it transported and rooted itself, you can have secondary cancer, which can happen in the liver tumor. So when we stage cancer, this is just trying to figure out what stage you're in. So that's what it means, like what how severe it is. So this is an essential way to standardize comparative studies of treatments and outcomes. So I'm here in Michigan. If I'm diagnosed with stage 1 cancer, if I go to California, stage 1 cancer is still the same thing. It's still stage 1. Okay. So it is very essential to be able to standardize these so that we can compare things without bias. And so this is used to estimate the prognosis. And the most common system used is called the TMN system. And the T is the size of the primary tumor. The N is the involvement of the regional lymph nodes. And then the M is the spread or the metastases of that tumor. So with carcinogenesis, okay, this is on page 553. This is the process where normal cells are transformed into cancer cells. And so the process varies greatly with respect to time. Cancer is thought to be a very multifactorial disease because it's not just one thing that can cause it or that can cause it to proliferate. So we have epigenetics, which is the environmental factors and effects. If I'm a smoker, I have a higher prevalence for developing cancers, right? If I live next to Chernobyl, probably have higher precedence of developing cancer. We also have the change in gene expression due to hereditary. So our genetics pass down from our parents that can affect it, and then also sometimes infection can cause it. So, for instance, cervical and hepatic cancers can start out just as an infection, right? And some cancers have well-established risk factors. So when we're talking about the stages of carcinogenesis, we have the initiating factors, and those are the procarcinogens, and these cause the first irreversible change in cellular DNA. And these do not create an active neoplasm, but they're kind of setting you up, right? Then you also have the exposure to the promoters, and this would include the hormones and the environmental chemicals that are going to help like exacerbate that progression. And these are going to cause further changes in the DNA, and these are less differentiated, and they increase the rate of mitosis, so the cellular division of the body cells, and or the lack of apoptosis. So they're telling you to grow without telling you to die, right? And then dysplasia or anaplasia may also be evident, and this process can lead to or does lead to tumor development. So looking at this is a big figure. It's figure 20.8 in your book, and this is on page 554. Okay, and so what this is showing you is over here on the left column are carcinogens, and then in the middle is going to be the process and the initiation, and down here is promoters, and then over here is the cellular effects. So for instance, if we look at this over here, this is the genetic oncogene factor, and it can cause irreversible irreversible, just to make sure that I said that correctly, mutation of the DNA. So you can see the one on top is the original, and then the one on the bottom here, you can see the color, a color of the nucleotides. So ATCG have the letters have changed. You have radiation and sun, and this can lead to the genetic changes. You also have a virus, and the virus, as well as this one would be cigarettes, and these can lead to this guy. And number 2 is repeated exposure to carcinogens, and this can add to like additional risk factors. Then down here for the promoters, you have hormones and food additives and industrial factors. And these can all lead to additional changes to the DNA and structure. And then when these compound, it can lead to cancer. On the other side over here, when we are looking at the cell and what happens, you have the normal cell with here, like here with the nucleus, and then the mutant cell. And so this little arrow coming up and pointing back to the original cell is possible intervention by DNA repair genes. And so what that means is your body has a lot of mistake repair mechanisms. You have base excision repair, mismatch repair, nucleotide excision repair, right? And homologous, non-homologous repair mechanisms. And so basically your body tries to catch any mistakes that are happening as they're being made so that it can't go beyond that. So it's kind of like I told you, I have a little bit of dyslexia. If I spell a word wrong, my brain catches it and say, okay, Janet, go back and put the I there instead of there, and fixes it and go on. The cellular repair mechanisms are kind of the same way. It's like, oh, no, we made a mistake. Let's go fix it. Let's move on and go on. But when we don't catch it, like maybe a repair mechanism is broken or one just slips through, then it can cause this proliferation of the initiated cells. And then that leads to membrane changes down here in step 2. And then with those membrane changes, this can lead to possible immune surveillance and destruction of the mutant cell. So again, your body's really good at trying to keep you alive and healthy. So your body will say, Mayday, 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 this is a bad cell. Let's go and attack it and fix it and break it apart and start over. And then they would destroy it, right? But sometimes, again, those slip through, or they're just so much that we can't catch them all. And then that mutant cell is going to proliferate or divide, right? And then that turns into the malignant cell. So I really like this figure, and I just explained it. But again, this is on page 554, and this is figure 20.8. When we're talking about risk factors, okay, and this is on page 555, we have genetic factors. And so these are oncogenes that regulate all growth. We also have viruses, and these are oncoviruses that can alter the host cell's DNA. And this is why I've told you since day one, viruses kind of scare me, right? Because A, we don't have control over them. B, they hijack our cells and take them over for themselves. And then C, they alter our DNA and say, nope, instead of making the real stuff, you're going to make what I tell you to do, right? And so this is one of the many reasons why viruses scare me. And also they mutate so quickly. I mean, again, we're in the middle of a pandemic right now with COVID-19, right? This second very virulent strand has come through, and it's now in the United States. So we're kind of starting again in a way on trying to figure out how to prevent and like inhibit the transition of these cells. Okay. You also have radiation that is a major risk factor. And so this would be from ultraviolet rays, too much sun, right? Without sunblock. When you're tanning, right? And I know they say that they screen out, the bad UV rays and stuff, but still, if you have to tan, do it in very low moderation. You also have X-rays and gamma rays, radioactive isotopes, and also the risk is increased with a higher cumulative dosage. And what that means is, for instance, say I have a bone disease and I break bones a lot, right? And I have, like, every week I'll have an X-ray. Right? Every week I'm exposed to X-rays and this radiation, right? And then that compounds, right? So over time, I have a higher risk of developing cancer because of this. An X-ray here and there, not a big deal. But this is why X-ray techs and stuff, they wear like the vests and they go out of the room or behind a wall so that they can reduce their exposure to this type of radiation. You also have chemicals. And so, in order to figure out which ones are bad or good, you have to check the health and safety information, right? But you have organic solvents, you have asbestos, you have heavy metals, you have formaldehyde, you have chemotherapy reagents. And so, my husband works at a university, right? And a lot of times he's pulling cable in asbestos rooms. And so they finally have told them, well, you need to stop doing that until it's abated, or else they just stop using that room. But I mean, this is something that we kind of have to worry about. I used to run a chemistry lab, and so I used to be working with solvents and chemicals all the time. Back in grad school, we had to fix tissues, right? So I was always around formaldehyde, but thankfully they had figured out that it was a carcinogenic agent, and so they made paraformaldehyde, so it's not as bad. Um, but chemotherapy reagents, just all of these things are risk factors that can lead to like accumulation and potentially the start of cancer in your body. You also have biologic factors. This would be like chronic irritation and inflammation, your age, your diet, your hormones, etc. So how can we reduce our our risks? Well, don't go tanning every day, right? Don't go sunbathing every day. I remember, I'm born in 77. Yes, I'm old. And my sister and I, we used to sit in the backyard with baby oil on us and tin foil to get even more sun. I ride horses, and so we showed in 4-H, and we would just be red as lobsters and peeling and blistering from all the sun because we were too cool to wear sunblock. I don't know, we were dumb kids, right? But so try to limit your UV exposure from the sun or from your tanning beds. Um, Also make sure to have regular medical and dental examinations. Do your self-examinations in the shower, right? Your diet. So increase your fiber content to make sure that you're pushing things through your GI system. Don't have a diet full of saturated fats, right? So reduce your fat load. And also try to have your fruits and vegetables. Again, those are going to have your antioxidants that can reduce the changes in the DNA, and as well as it has great fiber content. So what about immunity and cancer risks? Well, we have cell-mediated immunity, and this recognizes some tumor cells and it destroys them. You also have immunization for cervical cancer and hepatitis, and this is recommended to reduce cancer risks from infection. And so, what is it? Oh, I just had it on the tip of my tongue. The cervical cancer one that they started doing, I don't know, about 10 years ago for teens. I'm forgetting on what it's called. Gardasil, right? And so I don't know. That'd be something fun to talk about in class if it comes up. The pros and cons of that and whether or not it's a good thing. And that would just be all a opinion. Okay. Now working on treatment, and this is still on page 555. This treatment depends on the specific type of cancer you have. It can involve surgery, chemotherapy, immunotherapy, radiation, or a combination of the above. And so when we look at the effects of treatment on a solid tumor, this is on page 556, and this is figure 20.9. What you see here is, well, the key is that the straight line is the development of the tumor before treatment. The zigzag line here is the progress of the tumor after treatment. And then the little red dot is the size of the malignant tumor. And so down here you have the tumor growth. And then we have the signs that start to appear, and then you're diagnosed. Okay. Well, then you have an early surgery, and then you can do radiation and chemotherapy, and then you can have a cure. So you can see once you catch it, then we can really significantly decrease it. But if the cells and the cancer cells resist treatment, they can continue to grow. And so then you can have, or you don't catch it, and then you can have the late treatment, and this can include surgery, radiation, and or chemotherapy. And so then you can see we caught it later, but we still can have a pretty significant decrease, but it may reoccur. And then down here, if we have where it resists treatment or you don't catch it, then basically it can lead to death, or we can have palliative treatment, which just prolongs death. Okay, so reducing pain and making you comfortable before your body succumbs. Okay, so those would be the different effects of treatments on a solid tumor. So what is surgery? Well, this is on page 557. And the surgery is the removal of the tumor and the surrounding tissue. And this may be done with a laparoscope and several small incisions. And doing it this way is going to minimize tissue damage and it improves the recovery time. You also have to make sure to remove adequate surrounding tissues. These would be clear margins, and this may result in the change of function. And what this means is, okay, say I have cancer here and it's deep. Well, you're going to have to take a big chunk out, right? So I might not have full motility or rotational movement of my arm after that, right? So it just really depends on how much tissue has to be resected. You also have radiofrequency ablation, or RFA, and this is an alternative surgery for small single tumors in solid or fluid-filled organs, but you cannot do this in the lungs. You can also have radiation therapy, and this may be used alone or combined with other therapies, and this causes mutations or alterations in the target DNA. And this is the most effective way to treat rapidly dividing cells. Some types of cancers are radioresistant, and this may be used as an adjuvant therapy prior to surgery to shrink the tumor. So that means it's like a pre-treatment for the treatment. Methods of administration for radiation include external sources such as a cobalt machine. And this is where you are exposed to radiation for a short amount of time in a specific site in the body. And this is going to require multiple treatments. We also have internal insertions of radioactive material at the tumor site. And this would be to treat specific types of cancer, for example, cervical or oral tumors. You can also instill radioisotopes in a solution into a body cavity. And this is going to monitor, you have to monitor them to ensure that there's no leakage because you don't want like crazy radiation just flowing through your body. And the radioisotopes may be given by an injection or by an injection for specific tumors. Okay. So what about adverse effects, okay, of radiation? Well, they can cause bone marrow depression. Sorry, my brain is like not working with me today. So we have decreased leukocytes, and this can increase the risk of infections. You can have decreased erythrocytes, and this can cause fatigue and tissue breakdown. You can have decreased platelets, and this can cause excessive bleeding, right? So there's some things that can kind of not be so good if we have bone marrow depression. You can also have epithelial cell damage, and this can cause damage to the blood vessels and skin and lead to hair loss. You can also have a lead of infertility, and this can be caused by abdominal radiation. You can also have nonspecific fatigue and lethargy, and this can lead to mental depression because you just always feel very down and drained, right? So there's a lot of adverse effects to radiation. So what about chemo? Well, you use anti-neoplastic drugs, and this can be used alone or in combination with surgery or radiation. And this is usually given with a combination of 2 to 4 drugs, and they're given at different intervals. Okay, and so the classifications include anti-mitotics, anti-metabolites, alkylating agents, and antibiotics. And these drugs interfere with protein synthesis and or the replication. So here is back to when we were kind of talking about cell division and stuff. So how does this affect the cell cycle? How does chemotherapy affect the cell cycle? So this is figure 20.10, 20.10 on page 558 of your book. And so basically, this is AVBD therapy for Hodgkin's disease. And so you can see that, deoxyribonucleic, which is down here, is going to be blocking the S phase. Bleomycin inhibits the DNA synthesis in the S phase. Vinblast blocks mitosis, and dicarbenzine is affecting any phase. So basically, this is showing you which cycle of the cell replication each of these medications affects. Okay, so we get to target them in different ways. So the vinblastine is going to have an X here on mitosis, so it's going to block that. And so then what happens with that is that we have no further division or differentiation of neurons, for example. And then you have the GO, which is the resting state, And this is where we have the cell growth. And so, the maturation or the protein or RNA synthesis. So if we stop here, then these guys can't go on. So it's kind of like this wheel. If you stop here, then this can't happen. So that is an awesome little summary table of how the different parts of how the different pharmacologic agents can affect different parts of the cell cycle. So what about adverse effects of chemotherapy? Well, we kind of talked about these, right? We can have bone marrow depression. And this is a limiting factor with chemotherapy. The blood tests are taken before each treatment. And then nadir is the point of the lowest cell count. And this is different points. This is going to be different points in the different parts of the different cycle. So nadir is going to be the definitions on page 559. Okay, and it depends on the different drug on which cycle it's going to affect. And so if the count is too low, the treatment may need to be postponed, and antibiotics or hospitalization may be required. Okay. So there's a lot of different things that we just kind of keep monitoring to make sure that we're trying to keep you as healthy as we can, right? You could also have nausea, and this may occur prior to, during, or shortly after your treatment's occurring. And so what we do is we use antiemetic drugs, and these are useful for helping to decrease nausea. You can also have epithelial cell damage, and this can occur very easily, and this can also cause hair loss and the breakdown of skin and mucosa. So these are a lot of the side effects that you see in chemotherapy patients. You also can have damage to specific areas with some neoplastic drugs that are going to be used. You can also have fibrosis or fibroids that are occur and grow in the lungs. You can also have damage to myocardial cells, which are in your heart. You can also have kidney damage. So there's a lot of really bad things that happen, but it tries to save your life by killing the cancer. So there are some other drugs that we can use, and this is on page 559. So we can use blocking agents, and these are going to act to block the receptors or the growth promoters in cancer cells. We can also use biological response modifiers, and these are BRMs, and these are going to augment or enhance the natural immune response. We have angiogenesis inhibitors, and these can inhibit the stimulus for the growth of blood vessels. And we have analgesics, and these analgesics are prescribed to relieve the pain, right? Alleviate pain. And these may be used in high doses because it can be very painful to have all this happening in your body. We also have gene therapy, and gene therapy is an experimental cancer treatment. And this can be designed to replace the mutated genes with a healthy copy of the gene. It can inactivate a mutated gene. It can introduce a new gene. And so gene therapy is very cool. We're still kind of on cutting edge of things, and it's not as much mainstream. Hopefully in 10 years, this will be like the norm, and we can just, design pharmacologic approaches for specifically you, right? So it's pretty cool. We also have nutrition, and again, this is continued on page 560. Patients with advanced cancer are often malnourished, right? So they don't feel good. They're always queasy and just tired, and so they're not eating, and any of the nutrients that they do get, maybe different parts of the body are stealing it, right? So the contributing factors, again, can be a change in your taste sensation, anorexia, because you're just not eating, you're not feeling like it. If you do eat, or even if you don't, meds can make you vomit, and you can have diarrhea right from the treatments. You can also have a sore mouth, or you can have a loss of your teeth that occurs. It can cause pain and the treatment, etc., and the actual cancer can cause pain and fatigue. And then this malabsorption can be caused by inflammation of the digestive tract. So what about complementary therapies? And so these are ones that will just help you treat or cure, and they're non-medical therapies. And so that's why they're called complementary. And so these can include massage, meditation, counseling, exercise, therapeutic touch. Research-based evidence has not been published for the raw food macrobiotic diet or the use of insulin and glucose with chemotherapy. But, everything that you do can help, right? So if you're eating your whole natural foods that don't have the processed carcinogenic agents in them, then I can't see how that would be hurtful, right, or harmful. And also healthcare workers need to be aware of these different types of therapies to advise patients. So, if they're eating, McDonald's and processed foods all the time, have them switch to more of a natural food-based diet so that, you can not be at least hurting yourself, right? So what about the prognosis? So this is on page 561. And so cancer-free state is generally defined as a 5-year survival without reoccurrence. Some cancers, such as childhood leukemias, can be considered cured after a 10-year cancer-free period. And then we have remission. And the remission is where there's no clinical signs of cancer that's present, but the client can get cancer back, and so therefore they can experience several different repetitions of remission. And life expectancy and death rates for specific cancers can vary. So some examples of malignant tumors are going to be like skin cancer, and these are visible and easily diagnosed and treated. And there is very excellent prognosis for this, with the exception of a malignant melanoma. What about ovarian cancers? Well, these are poor prognosis because we can't see our ovaries, right? We just kind of feel them when there's something wrong, and usually when there's something wrong, it's already kind of advanced. And so because of the hidden nature of the cancer on our ovaries, we don't really get to see it, and so these unfortunately have high mortality rates. And brain tumors, both benign and malignant tumors, are life-threatening, I said at the very beginning, because of location, okay? Depending on the location, it can compress the different parts of your brain tissue and potentially cause some very bad things to happen, even if it's malignant. Or, I'm sorry, benign. And the primary tumor is usually fatal, therefore, there's usually no metastases or spreading because that original one kind of does you in. So this is a picture, and this is figure 20.11, so 20.11, and this is an example of a basal cell carcinoma. So you can see that it's irregular shaped, it's raised, it's red, it's kind of puckered in the middle. Okay, so this is the kind of things that you'd want to be looking for on your body when you're doing those screenings. Well, what about our brain tumors? Okay, we've talked about them a little bit of time, or a couple times, and we talk about how they can be potentially not very good. Well, I mean, no tumor is good, right? So this is figure 20.12 on page 562. And so what you can see is you have A, B, C, D, E, etc. And so A and D, which would be the frontal astrocytoma and the meningioma, these are both tumors on the surface of the brain. Where down here you have a pituitary adenoma, and this pituitary tumor causes the neurologic dysfunction and hormonal imbalances and abnormalities that can cause even further problems. Down here in C, you have your cerebral tumor, and even when this is small, it can interfere with vital brainstem functions. So remember, your brainstem is where your heart rate, your breathing, your balance, all of that is located. Okay. For E, you have glioblastoma, and there's over here too. And these are tumors in the interior of the brain that can shift the ventricles and interfere with the flow of cerebral spinal fluid. So cerebral spinal fluid, I worked on hydrocephalus for 15 years or at least, right? So what this does is it carries nutrients, it gets away the debris, etc. And it's like it provides cushioning for your brain tissue, okay? And so if you get in the way of this, it can cause damming up effects, which can cause you to have hydrocephalus because there's flow problems. It can cause nutrient deficiency. It can cause a lot of different things. And then F down here would be multiple metastases. And so you have, for instance, a metastatic tumor that has spread up from the lung. Okay, so no bueno. What about cancer incidence? Well, cancer is most common in men, and the forms of cancer include prostate cancer, lung cancer, and colorectal commons. And the cancers that are most common in women are going to be breast cancer, lung cancer, and colorectal cancer. Now, men can get breast cancer, and so, you always have to be aware, even if it's, we don't have a prostate as a woman, so obviously we can't get prostate cancer. Men can't get uterine cancer, cervical cancer, right? But the other types of cancers, even though, for instance, lung cancer might be more prevalent in males, females can get it as well. All right, so thank you for coming to your chapter 20 lecture on cancer, and we'll see you in a few for the next chapter. Thanks.